And so you guys not likely to come in the exam, but just have an idea what it is. Okay. All right, so let's start for today's lecture. All right, Blair, can you tell me what this is?
Morning, Doc. So this is a pigtail catheter that we can see on the left-hand side.
Right,
Let me
that's
get the
good.
printer.
Very good.
Right, so this is a pigtail catheter. It is coiled at one end and it has openings for it to allow for drainage. And it also has a locking port at the end with a string. So on the right-hand side, this is a abdominal pelvic X-ray. You can see bilateral nephrostomy tubes in situ.
Very good. Very good. So Blair, this is a 45-year-old female who presented to the general practitioner feeling generally unwell. Skin scratching, has swelling of the face and feet and legs, and has 3 children, history of 3 children before, sexually active, multiple partners, history of PV bleeding, and you did an ultrasound that shows bilateral hydronephrosis hydroureter, and the UNE's renal impairment with potassium 6, 115 creatinine 900. If you put everything together, what do you think this patient likely to have?
Okay, so just to clarify the history, you said that the patient had a bilateral hydronephrosis
That's
and
correct.
a history of infection. Sorry.
No, I didn't say that.
Okay. Um, you said the patient is sexually active. I'm thinking. I mean, the bun and creatinine were elevated, so I'm thinking that this could be infectious or pyelonephritis.
Can be, but no, that's not it. Pyelonephritis was a clinical presentation with pyelonephritis.
Okay, so with pyelonephritis,
Does it typically give you renal failure?
no, it doesn't. You have like your
What is the
fever and flank
right?
flank tenderness
Very good. So
and
this patient,
urinary symptoms.
right? This patient has no fever and no tenderness. So what do you think this patient has?
Okay, so it could be an obstruction.
It could be
So
anything, but what do you think it is?
I'm thinking a ureteric obstruction. So a stone.
No, that's probably not it. Carrie Ann, tell me, what do you think this patient has?
Doc, I'm trying to understand the history a little more. Could you repeat for me, sorry? I heard the bilateral hydronephrosis.
45-year-old lady, sexually active, multiple sexual partners. Presented to GP with generalized swelling, skin itching, right? And when you do the ultrasound, you show bilateral hydronephrosis hydroureter. UNE's potassium 6, 115, creatinine 900.
Is it is it possible that this patient has HIV?
I can't hear you. Say that again, please.
Hello, Doc. Can you hear me now?
Yeah.
It's possible that this patient has HIV. I'm not 100% sure.
So how HIV give you bilateral hydronephrosis hydroureter? All right, Matthew, your turn.
Doc, I'm thinking.
That's a good sign.
Doc, I'm really not sure.
All right. You guys did gynecology already?
Yes, sir.
Okay. You guys know anything about cancer of the cervix?
Oh yes, thought that it can invade the ureters.
All right, Blair, tell me about cancer of the cervix.
Okay. So usually cervical cancer is linked to HPV infection. So the ones that are associated with cancer would be 11 and 16. Um, Usually, these patients um, present like over 35 years old. Um, you have certain risk factors, so like sexual activity, especially without a viral method, so your condoms especially. Um, if these patients are of poor socioeconomic status as well, um, in terms of the presentation, these patients can present with um, vaginal bleeding, which tends to be abnormal. So it could be in between periods, um, intermittent.
Okay, that's good. That's good. Okay. You have some ideas. So, but all right. So the typical scenario I present is patient with infiltrative or invasive cancer of the cervix, infiltrating the distal ureter, leading to bilateral hydronephrosis, hydroureter. Right. So that is what happens. All right. So you guys need to read up cancer of the cervix, right? And it is fairly common for them to present with renal failure secondary to distal ureteric obstruction from cancer of the cervix, right? And in your exam, that's typically what we would show. We will show you this X-ray. You described it well, Blair, and so the next step would give you a scenario, and you can have to tie in the X-ray with the scenario. So, patient with cancer of cervix, bilateral hydronephrosis, hydroureter. I was going to ask you how you treat it. You put in bilateral nephrostomy tube so you can stent the patient. But typically with patients with cancer, it's hard to stent patients, okay? So nephrostomy tube. All right, Karian, your turn. CM X-ray, right? You heard Blair describe the X-ray. That's very good. So now, let's suppose this is a 65-year-old man who history of obstructive lower urinary tract symptoms or voiding urinary tract symptoms, and presented with decreased urine output, obstructive urinary symptoms, and you did the blood test. The serum UN is creatinine 6, BUN 15, creatinine 2, 900, and PSA is 50. And ultrasound shows bilateral hydronephrosis hydroureter. What do you think this patient can have?
I'm thinking this patient can have prostate cancer or another different cell could be BPH.
Very good. So let's walk me through how BPH caused this clinical scenario.
Alright, so with BPH, there's so basically BPH, there's glandular enlargement of the prostate. So what and then because the urethra.
What do you mean by glandular enlargement? Prostate is a gland.
So
So what BPH stands for?
so benign prostatic hypertrophy. So in my
Wrong,
read,
wrong, 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 wrong. You guys got a BPH lecture already?
In third year, Doc.
Yeah, so you got it already, right?
Yes,
All
Doc.
right, all right, Matthew, what BPH stands for?
Benign prostatic hyperplasia.
Right, so carry on. So it's hyperplasia rather than hypertrophy. So do
Oh,
you know the difference
okay.
between hyperplasia and hypertrophy?
So hyperplasia would be an increase in the number of cells, basically. For hypertrophy would actually be the opposite.
What
Basically,
opposite means a decrease in the number of cells?
well, how to explain?
So what is hypertrophy then?
So hypertrophy is so hyperplasia is an increase in the growth of the cells, and then hypertrophy is an increase in the size of the cells itself.
Um, you're kind of right, but I would barely pass you in the exam, but it's okay. But hyperplasia is a disorder of growth characterized by increasing the size of an organ by increasing in the number of cells in the organ. While hypertrophy is a disorder of growth characterized by increasing the size of an organ by increasing in the size of the cells within the organ. All right. So BPH is benign prostatic hyperplasia. So carry on, back to you. So how BPH caused that clinical scenario? Just walk me through it.
So basically, what happens, and I can remember from my reading, is that you have hyperplasia of the glandular epithelium and also the connective tissue. So what happens is that it affects the transitional zone of the prostate, and then this forms like an enlargement. And if using anatomy, the urethra normally runs through the prostate. So with this enlargement, it causes an
So how
obstruction.
does BPH cause renal failure? That's what and hydronephrosis. I'm
So it
trying to
causes
understand that.
so it causes an obstruction, and then this obstruction causes basically a backflow of urine, and then this patient has problems voiding basically. So they have problems with storing and voiding urine. So this
So
backflow,
do all BPH patients have renal failure?
no, doc. I think it depends on the degree of
All right,
hyperplasia.
so all right, patient in acute retention does and do all patients with severe acute retention of urine have renal failure and hydronephrosis?
No, doc.
So what specifically causes some patients with BPH um, having renal failure, bilateral hydronephrosis?
So it happens more when these patients are chronic. So
Patients are chronic. Give me the medical term. Chronic what?
when they have chronic urinary retention.
Very good. Chronic urinary retention. All right. So in the exam, don't you're kind of beating around the bush. All I want to hear is that this patient has chronic urinary retention, right?
Okay, doc.
All right. So that is how BPH can cause that scenario. And you said that one differential would be prostate cancer. So how prostate cancer caused this scenario?
It's actually similar.
No,
So
no. It can be similar, but no.
yeah, like I was thinking about it in that way.
No, what else?
So with prostate cancer, it's the medial lobe that's affected.
No,
Or
no, 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 carrier, no. No, it's not the median load. So, all right, Matthew, how prostate cancer can lead to the clinical scenario I described? And don't tell me you're thinking.
No, doc. So basically, with prostate cancer, it tends to be with the peripheral zone, which is affected in these patients. So it tends to have a later presentation in terms of obstruction, and it's more to do with
No,
like in.
well, I wouldn't say that. I don't know about that. But
Oh,
how prostate cancer causes bilateral hydronephrosis? And Karian already said that it can be enlarged and caused with similar to BPH. I said that yeah, that can happen, but what else? How else can prostate cancer lead to renal failure?
Invasion, like metstock, like metastasis. So basically, like if it spreads to probably the urethra, for example.
Prostate cancer spreads to urethra? No, not likely.
Okay. If it's invasion of the bladder out, no.
It can be. It can invade. It can grow and invade and grow and obstruct the ureteric orifice. Yeah, that could be one.
Oh,
But
okay.
how else? How else? All right, so it can spread to the pelvic lymph nodes. And remember, I told you the ureter drapes across the bifurcation of internal and external iliac arteries, and you have the obturator nodes and the pelvic lymph nodes, the iliac group of lymph nodes there, and cancer can have lymph nodes spread, and those enlarged lymph nodes compress the ureter, typically at the bifurcation of the internal and external iliac arteries, and that can give you bilateral hydronephrosis, hydroureter. All right. So Matthew, still you. Know that this patient presents to you. You're the doctor in charge of him, right? With swelling, PSA 50, right? UNEs as I described. And then when you do the rectal examination, you feel a hard nodule. So walk me through how you manage this patient. So potassium 6, decreased urine output, like there's not much urine produced. 15, creatinine 900.
Okay, so given that you've done those investigations already, and I would want to take the patient's vitals, make sure that the patient is stable.
Definitive management, sir. Tell me how you're going to treat this guy. What are you going to do?
Well, first thing I would want to attempt is to pass a urinary catheter in the patient. Try and
All right, so you pass it and bladder empty.
Okay, good. I'll probably want to use like an indwelling catheter to to continue urine outflow. I'd also want to do further investigations in the patient. So I would probably consider doing things like CT of the pelvis, essentially.
So what kind of CT you going to do?
What kind of CT? CT urogram.
This patient have potassium of 6, creatinine of 900. You're going to give him contrast?
Okay, no, that's not the best option. Ultrasound then, doc.
So why would you not give him contrast?
Because remember, well, with contrast it can be nephrotoxic to the patient. It is nephrotoxic. So if you don't have properly functioning kidneys, you basically cause patient demise.
Patient demise? No, I wouldn't, not necessarily demise, but you worsen renal function. Anyway,
okay.
we digress. Come back.
Yeah, so I would actually do that.
All right, so what is the most urgent thing in this patient? The man not passing urine, bilateral hydronephrosis, hydroureter, potassium high, blood creatinine in the range. The patient swell up.
Yes, he still has a hydronephrotic kidney, so you want to pass this the single J, the pigtail catheter, bilaterally as well.
You want to put in nephrostomy tubes?
Yes, nephrostomy tubes, doc. Yes.
Oh, yeah. That's it. You put in nephrostomy tubes. After you put in nephrostomy tubes, the renal function improved, potassium back to normal, bone and creatinine back to normal. What else are you going to do for this patient? And the swelling go down, the patient diuresing, and you replace fluid. Remember I told you to read a post-obstructive diuresis, right? Right, Matthew?
No, doc, I don't remember that.
Anyway, read a post-obstructive diuresis.
Okay, doc, noted.
All right. so this guy, what else are you going to do for this patient?
I would like to do a transurethral resection of the prostate.
Why?
Well, given that the tumor is causing the obstruction,
What
um,
tumor?
the hyperplasia, the BPH is causing the obstruction. I'd like to remove the prostate. So
How
yeah.
you know it's BPH? I just told you that DRE is malignant feeling with a hard nodule and PSA is 50.
So, oh, sorry, doc. I got mixed up with Carrion's history. Sorry about that. No, okay. So then I'd like to take biopsy of the prostate.
How do you do a prostate biopsy? And what
So
is the indication for prostate biopsy?
the the indication would be essentially once you suspect malignancy.
You guys did the prostate cancer lecture already, right? This is your last week of final year, correct?
No, doc, you actually haven't gotten it yet.
How come?
Doc rescheduled, so we have it this week instead.
Okay, so you guys need to read up prostate cancer screening and investigation and how prostate cancer present, right? So basically, in your exam, see, with this one simple apparatus or one simple X-ray, you can ask a lot of questions, and that's how your exam going to be. The questions, I'm not going to just ask you, what is this? You identify it, and say, all right, forget it. So the questions are related to the instrument or whatever I show you, okay? So that's how your exam going to go. So be careful. When you describe is curl catheter, retention mechanism, string to keep the coil. Read up how you pass nephrostomy tube. I doubt they're going to ask you that, but just in case. It's ultrasonic guidance, radiologists do it and stuff, right? All right, so that's nephrostomy tube. All right, who? Chukwananu, I hope I pronounced your name correctly. Tell me, what is this thing? Just focus on the instrument in the bottom of the picture, this one. I can't hear you. If you hear me, just say yes. All right, Denzel, your turn. What is this?
All right, morning, sir. So the instrument that we have before us is a urethral sound or urethral dilator. Of note, it has a proximal and distal end. The proximal end has a blunt tip and is angulated, whereas the distal end would have the distal end should have some numbers that would tell us the diameter of the proximal and distal.
All right, see the number here?
Right, so the top number should tell us the diameter of the proximal end, and the bottom number should tell us the diameter of the base.
Very good. So what do you use this instrument for?
So we use this instrument for urethral dilation.
So how do you use it?
So we pass this, it's a rigid instrument. We pass it blindly, and we basically gradually increase the diameter with different instruments based on the diameter of the instrument. But it's really for the urologist to do it, not anyone below that level.
Why?
Because of the complications that can be associated with it, such as hematuria, perforation, because it's a rigid and it's a blind procedure. So hematuria, perforation, stricture formation. Yeah.
Okay, all right. Not bad, not bad. I'll pass you. So this is a urethral zone or urethral bougie or a urethral dilator. It is archaic or old instrument. Most people don't use it anymore. Urologists used it to dilate soft urethral strictures or used to calibrate the urethra after the surgeries. Calibrate means to see how wide the urethra is. And it is a dangerous instrument because you pass it blindly. And so in your exam, so that this is an instrument rigid and you pass it blindly, so it's dangerous for anybody who is not experienced to use it because you can get complications like trauma. It can cause urethral trauma, bleeding, right? And so you wouldn't use it. You use it to leave it to the urologist. Very good, Denzel. The top one is another urethral zone, but unlike the both ends are different sizes, so that instead of so this one instrument is equivalent to two of these, right? So just have an idea what it look like, and you have the number 21 means the 21 French here. All right, so that's urethral zone. This will come in the exam, right? And just read it up. Basically, just recognize the complications of usage, what to use it for. Just have an idea of the numbers, and then just so that you typically don't pass it. You leave it to the experienced urologist who pass it. All right. Mr. Chuko Nalu, I hope you fix your internet problem. So tell me, what is this? What is it? What is this? I can't hear you. All right, Blair, what is this?
Okay, so this is a Hagar dilator. It is a metal rod which is curved. It is double-ended, so each of the ends are different sizes. So this is usually used in women for cervical dilatation. So whether it would be to ripen the cervix in labor or for a DNC.
All right, good for procedures. All right, very good, very good. Urologists use this to dilate the female urethra. And then sometimes we use this as a probe during a urological surgery. So read up urethral bougie, read up Hagar dilators, okay? All right, this is not likely to come in the exam. I just want to show you guys just for completion's sake. So this is, if you see something like this is a cystoscope sheet, the bridge. Semi-rigid lens. So sorry. So in case you guys get this in the exam, you know what it is. Not likely to come. All right. Who I reach? Let me go from back to front. Matthew.
Yes, sir.
An 85-year-old man presents with acute urinary retention and was catheterized without difficulty with a size 16 Foley urethral catheter. His creatinine was elevated 5 times above normal, but after 3 days on catheter drainage, it returned to normal. PRE is a benign enlarged prostate. Flexible cystoscopy afterwards shows that there's an enlarged obstructing prostate. He has no comorbid conditions and attends to his garden daily. The most suitable advice and option to the patient would be, what would you do for this patient?
So, given that this patient has like a lifestyle and everything, I would recommend surgical management for this patient. So, given that it's a given the history that it's a benign enlarged benign prostate, I would then do a transurethral resection of the prostate.
Very good. Why not try him on tamsulosin and finasteride?
So, okay, so those are the alpha adrenergic blockers, which will relax the bladder neck. Um, okay,
Right,
because the patient might
which one of
eventually,
those is the alpha blocker?
sorry,
Which one of those?
tam, the
I
tam,
mentioned
tam,
two medication.
the tamsulosin,
I don't know what medication is that. Say it again.
not the tamsulosin.
I don't know what that is. It's tamsulosin.
Oh, sorry, doc. Okay, sorry, tamsulosin.
Be careful in the exam. Don't make up words. Don't make up medication.
Understood, doc.
All right. So that's the alpha blocker because when you do that now, I'm going to automatically assume you don't know pharmacology. You don't know that medication. Right?
Understood.
Okay. So, and I also mentioned finasteride, right? So what is finasteride?
I cannot recall that one, doc.
Okay, carry on. What is finasteride?
It's a 5-alpha reductase inhibitor.
Very good. So how does that work for BPH?
Okay, so these drugs, they inhibit the conversion of testosterone to dihydrotestosterone, and that's the most active form of androgen that will be used. So by inhibiting this, I believe it decreases the size. It helps decrease the
Um,
size of the prostate.
okay, that's good enough for the exam. Yeah, it decreases the size of the prostate. So the question is, carry on. So Matthew said that he going to offer him surgery and do a TURP on the patient, which I agree. So the question is, why would you not try medical treatment for this patient? Why would you not give him combination alpha blocker and a 5-alpha reductase inhibitor?
Okay, because this wouldn't. Um, Alright, so you mentioned he has no comorbid conditions and he attends his garden daily. I believe giving him these drugs would actually not give, and then he would probably have to keep in an indwelling catheter. Um, so with all
No,
of this,
but a lot of patients with retention, I give them good medication and they have successful trial avoiding. So why would you not give this patient medication?
because of his creatinine levels being 5 times above
Because he
normal.
has renal impairment.
Yes, sir.
Okay, all right, very good. And review your BPH lecture and read up chronic urinary retention, okay?
Yes, sir.
All right, so, all right, carry on. Pick one, although this is supposed to be Matthew's question.
So the answer would be C.
Very good. All right, let's go to your question now. Carry on, your turn.
Okay, so I mentioned the 5-alpha reductase inhibitor, and then there's alpha adrenergic blocking agents.
So pick the answer.
So that would be B.
What's that?
B.
B? All right. This is too easy. Still you. What are the indications for surgical treatment for BPH? Tell me some.
Okay, so one would be if the patient has chronic urinary retention.
Very good. Which our patient had.
Another is renal failure.
All right. No, that's failed medical. That is a chronic urinary retention. Next.
Okay, so failed medical treatment, as you mentioned.
Yes. Okay.
And I'm not sure if this will be an indication, but a patient who a more younger patient where the
No. Mm-mm.
Complications of BPH. So if the patient
Very good.
has stone.
Right. Recurrent infection, etc. All right. So pick one.
So the answer will be C.
C. Right. Because in acute retention, you can try medication, right? Very good. All right, Denzel, your turn. What is removing an open prostatectomy?
That would be the enlargement, the adenomatous enlargement. So,
Okay, so tell me, what's the difference between open prostatectomy and a radical prostatectomy? It might be unfair because you don't get that lecture, but I guess life is unfair, Denzel. Come tell me, you know?
the difference between an open and the radical.
Yeah. All right.
Right.
Open is
So
for
for
PTH
the
and radical
radical,
is for cancer.
would be okay.
All right, and if since you're getting prostate cancer lecture later on this week, I won't dwell on that. But pick one. What's the answer, Denzel?
Would be B, sir.
All right, good. All right, Denzel, still you. With regard to prostate cancer, major etiological risk factor is, what are the risk factors for prostate cancer?
Right. Ethnicity
Don't know.
is a risk factor.
Okay, good.
Right. So African ethnicity. Yes, sir.
All right. So anything else on the slide can be a risk factor.
Well, cigarette smoking could also be a risk
No,
factor.
the answer is no. There's none.
Okay.
All right. Don't buy lotto today. You're not very lucky today, sir. So it's no. All right. So, all right. What people find is that people of African descent in the New World typically has a higher incidence of prostate cancer and also has a higher incidence of aggressive prostate cancer at the time of diagnosis. It may be due to genetics, maybe due to the social economic factors, or a combination of both. Okay. All right. Chukwanano, should I try you one more time? What modalities are utilized for screening for prostate cancer? All right, probably not going to work. Blair, your turn.
Okay, sir. So for screening, usually you use your PSA.
All right, so, okay. Don't say use your PSA.
Sorry, you use the PSA.
Okay. What is PSA?
That is the prostate-specific antigen,
What is that?
which is a protein produced by the prostate. Usually, it's found in ejaculation fluid. Um, it's supposed to help with fertility, so penetrating the cervical mucus, motility of the sperm.
You have a basic idea. Okay, so it's a serine protease. It breaks down protein, as the name suggests, it's an enzyme. It liquefies semen, and when the semen, at the time of ejaculation, the ejaculate is a coagulum, it's viscous. PSA is thought to liquefy semen, make the ejaculate more less viscous, and this aids in the motility of sperm, and it also thought to break down the cervical mucus, further aid in the motility of sperm. Okay, very good. And PSA is specific to prostate tissue, right? So you just told me PSA. What else can you use to, what else is utilized in the screening for prostate cancer?
You also use the DRE, direct rectal
What is DRE?
examination. Your direct
What is,
rectal examination.
okay,
Digital
good.
rectal examination.
All right, so if the digital rectal examination is normal and the PSA is less than 4, what is the risk of that patient having prostate cancer?
So the risk would be low.
Okay, very good. All right. Okay, so it's probably 7% or less than 10%. All right, I doubt they can ask you those things in the exam. So screening for prostate cancer utilizes PSA, okay? Clear, still you. A 69-year-old male on routine annual examination was found to have a benign feeling prostate. A PSA performed as a part of his annual examination was 25 nanograms per ml. As a result of the elevated PSA, a transrectal ultrasound of the prostate was performed and a biopsy done. Histology revealed the presence of adenoma of the prostate. CT shows no pelvic lesions. His TNM staging would be
Sir, can we go through the options?
all right.
Okay, so for this patient, I would go with option D, T1 and 0 and 0.
Very good. Anyway, pay attention to the TNN staging when you get the lecture, okay? All right, Matthew, your turn again. Oh my goodness. 60-year-old man presents to the emergency room in acute urinary retention. So as you know, with acute retention, it's boiling in pain, the belly distended is rolling all over the place. And you put this UCAT and you tried urethral catheterization and failed. What is the next step?
So then I would want to do a suprapubic catheterization in this patient, doc.
Good. So which one is that? Pick one.
So that would be option C, suprapubic cystectomy.
Right. Too easy for you. Next one. You again, Matthew. 41-year-old male sustains a crush injury to the pelvis. Right, he's a taxi driver, head-on collision with a truck, and the steering wheel and the front end hit against the driver's seat, and his pelvis crushed. And he is noted to have blood in the urethral meatus. What is the likely injury regarding the urinary system?
So this is most likely going to be a urethral injury.
So what would you do?
So for this patient, then I'd want to do a retrograde, a retrograde urethrogram.
How do you do a retrograde urethrogram?
So you will insert a catheter into the urethra, and then you inject the contrast, and then you use X-ray imaging to basically look for the tract.
The urethra is long.
So okay,
right?
particularly into like the navicular fossa area.
Okay, so say that. All right, good. Dr. Chin showed you urethrogram pictures.
I think it was just one picture, if anything, doc.
All right, Google the rest. All right.
Yes,
good.
doc.
All right, Matthew, pick one. Which one?
Okay, so it would be B, doc.
All right, why would you not put in a urethral catheter?
Okay, so because this patient, we're suspecting a urethral injury, we don't want to insert a urinary catheter one time because we don't want the urinary catheter to go into a false tract, or we don't want to, yeah.
You don't want to aggravate the injury. You don't want to make the injury worse.
Yes, doc, exactly.
All right, carry on. A 21-year-old male presents to the emergency room in acute urinary retention. He has a past history of a sexually transmitted infection that was untreated. Right, he has gonorrhea, right? So I'm pouring yellow-green pus from the urethra. And then he is having problem passing urine. The likely cause of his urinary retention is?
D, urethral stricture.
Yes, urethral stricture. Very good. So gonorrhea typically give you bulbar strictures, right? All right, carry on, that's too easy. What is the optimal investigation of gross hematuria secondary to renal trauma? You got hematuria lecture already, right, from Dr. Chin?
Yes, that we do.
Oh, perfect. Tell me what to answer.
CT urogram.
CT scan, very good. That is too easy. You again. 25-year-old male patient presents with right loin to groin pain over the past 4 hours, blood in the urine and burning when he pees. He has right renal angle tenderness but a soft, non-tender abdomen. This likely is, oh, I wonder who highlights it. What's the answer?
That's what I was thinking. That D.
All right, so how would you treat this patient?
Alright, so let me just read it again. So it depends on the size of the stone. So some stones, I believe it's 5 millimeters. If that can actually, those
All right, this
can
one is
actually be treated
all
conservatively.
right. So you did the CT. It shows an 8 millimeter stone in the distal right ureter with mild hydronephrosis, ureter above it. The renal function is normal. So how would you treat this patient?
So in my reading, if the patient has hydronephrosis, you'd want
I
to do.
don't ask the question in my reading
Okay,
and
so
go
you
to
want to
right.
do a uterus cup for the stone.
Not exactly wrong, but not exactly right either. So this patient in pain, so you need to resuscitate the patient, right? And you need to give him analgesics, correct? Right? If the pain settles with analgesics, you can try a course of medical expulsion therapy. You guys did renal stones already, right? You guys did the lecture on renal stones?
No, doc, but no, we didn't do a lecture. Only in third year.
Yes, in third year. Remember, your exam is med school exam, not third year, fourth year, fifth year exam. You guys need to, so anything can come in your exam, as I said before, right? So read up treatment of ureteric stones, right? You can try medical expulsion therapy, all right? Hi, Denzel, your turn. Yeah, hi. Yes, Matthew.
Sorry, Doc, just a quick question concerning the hydronephrosis, right?
Right.
For that patient, given the stone, so basically you just do the medical expulsion trial, right? But then
You can.
that would relieve the hydronephrosis. You don't want to put in like a nephrostomy tube or anything prior?
No, no.
No?
If the
Okay.
stone, if the patient's pain controlled, the renal function normal, you can, and it's in the distal ureter, you can try medication, right? Another answer, if you say that he has hydronephrosis, I would put in a double J stent. I would accept that answer too. That's why I tell you to read up treatment for ureteric stones. Right? In your exam, they can ask you treatment for the stone. What would you do? Typically, they're going to give you an X-ray, and Dr. Chin went through ureteric stone X-rays with you guys, right? So typically, they will give you an X-ray and shows a distal ureteric opacity in the pelvis in line with the distal ureter. And you would say, boy, it looked like a distal ureteric stone. So the next logical question would, what would you do for this patient? How would you treat it, right? So although I'm giving you this scenario, but that's how your exam going to be, right? So read up ureteric stone, okay? All right, Denzel, come. You have a long time to read this question. So tell me, what's the answer?
Right, sir. So we want to start off by resuscitating the patient. We want to take up bloods, so CBCs to check for the patient is anemic, white blood cells because the patient has a fever, so we want to check if there's
So what do you think this patient likely to have?
presence of infection.
Okay.
Right, so with the hydronephrosis, I think the patient might have a pyelonephritis. So we'll also want to
what caused the all
give
right,
the
come
patient
again.
antibiotics.
All right, hold on, read the whole thing. The answer is right in front of you. What does patient have?
Patient has a stone, sir, a left ureteric stone that's causing the hydronephrosis.
A left what? I can't hear you. A left what? No, you said something. I didn't hear you, so just repeat it now.
A left renal stone, sir, renal pelvic stone.
Okay, yeah, all right.
You hear me better now,
Denzel,
sir?
you have to internalize what
Right.
you read. So this
a left
patient have a
ureteric stone.
obstructing left what? Say that again. Left
Renal
what?
stone, sir.
All right. We keep
A
hearing
left
ureteric.
renal.
I keep hearing ureteric. That's why I keep stopping. There's nowhere that's a ureteric. Left renal pelvic stone. So this patient has an obstructing left renal pelvic stone with infected hydronephrosis. How you know it's infected? Fever, vomiting, and pain. Okay. So what would you do? So you tell me, say you
Patient has a left renal
resuscitate, you take
pelvic
bloods.
stone.
Tell me the definitive management.
Right, so start off by giving the patient empirical antibiotics. We'll
What
want to give
empirical
them
antibiotics?
third generation cephalosporin to start.
Such as? Name one third generation. Okay, okay. All right, what else?
Yes, I'm having a bit of a lag on my end. That's the answers are coming in slow. We'll also want to give the patient analgesia, such as baralgin, which could also have antispasmodic properties.
Okay, what else?
And then we want to do percutaneous drainage.
Okay, so what percutaneous drainage will you use?
Nephrostomy. Nephrostomy.
All right, good. All right, good. Pick one.
Option B, sir.
Very good. All right, Denzel, you again. Radiolucent urinary tract stones include? Dr. Chin must have went through this with you guys. All right, I open to the floor. Anybody?
Uric acid stones, sir.
Yeah, uric acid stones. Good. All right, uric acid stones. All right, clear. The most common presentation of bladder tumor is?
It'd be painless hematuria. I'd go with total, sir.
Yeah. Gross total penis hematuria. All right, cool. All right, I open to anybody. What is Stolfels or Staffel syndrome?
The answer would be C, sir. Liver dysfunction.
Right. So that can come in your exam. All right, guys. You guys did pretty well, despite me bullying you guys. So between me and Dr. Chin, we give you an idea what your clinical exam is likely to be, right? And basically, identifying the instrument, describing the X-ray is just the first step. And the real exam is actually describing the management of patients, because you're going to manage these patients when you become an intern, become a doctor, right? And I can't impart knowledge to you because you have to learn it yourself, but I can guide you in terms of what you need to know. And so you have a lot of reading to do, but your exam is not until next year, May, so you have a lot of time, correct? So, and now that you have an idea what your clinical exam is likely to be, just reorient your reading and studying towards how to answer the exams, right? So you guys need to have background knowledge of, like for today, within the nephrostomy tube, you need to have background knowledge of cancer of the cervix, BPH, stones, prostate cancer, right? Or even bladder cancer. And so read around it, and then be more vigilant when you're on the wards, although you guys not on the wards these days. So as I said the last lecture, anything can come in your exam. So make sure you know to say something on everything. So for example, the dipstick, urine dipstick, you can get that. I'm going to ask you in the exam, what you check for this. And then if you tell me specific gravity, I can ask you what it mean, what it measure. Or if you send me proteins or blood, ask you what give you false positive, false negative. All right. How to pass an NG tube is a common question. Chest tube and underwater seal is a common question. Different sutures, common question. You're going to get red top tube, blue top tube, purple top tube, gray top tube. They're going to ask you what's in it, what you use it for, and can give you, like, for example, patient, you're resuscitating patient. They're going to ask you which tube you're going to use to do group and cross match or blah, 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 right? Read up sutures, anesthetic instruments, very common, a whole heap of x-rays, orthopedic x-rays, general surgery x-rays. In the exam, you can also you have a TV screen and they have different pictures. Like, for example, you can get chronic venous ulcers, chronic venous insufficiency, decubitus ulcers, patients with neck swelling, hernias, hydrocele. So those things are routine in your exams and can give you picture or apical lesion, barium enema. They can give you contrast on the table and tell me what this is. NG tubes, as I said, nasal cannulas, oxygen rebreathing bags, urine bags, and all the urology appliances I told you about. All right. And then, so a lot of reading, but if you answer questions like how you answer in the exam, in this session, I can't see any of you failing, right? So that's how easy the exam will be, all right? So just don't make silly mistakes, don't get too nervous, and just go through the exam and you'll do well. All right, guys, any questions for me? Seeing that there are no questions, well, good luck, guys. I guess I'll see you guys when you're doing your exams. Have a good day.
Thank you.
Thank you, Doc.
You're most welcome. I hope this helps you.
It did.
Definitely.
So, all right, have a good day, and I see you guys whenever. All right, take care.
Yes, Doc. And please don't forget to stop the recording.
Yeah.